So with that, welcome again to today's session of the Tennessee Harm Reduction Project ECHO. Today's topic is stimulant use and harm reduction, practical strategies for providers. Today we'll have our didactic presentation followed by scenario presentation and Q&A. We're also using Menti as per usual with question boxes and anonymous participation if that's what you prefer. Next slide. Our speaker today is Dr. Phillip Coffin, a board-certified internal medicine, infectious disease, and addiction medicine practitioner. He runs the Center on Substance Abuse and Health in San Francisco, where he researches medications for multiple substance use disorders and other interventions addressing substance use and health. So welcome, Dr. Coffin, and just let us know when you'd like us to advance the slide.
Great, thanks, Anastasia. I'm going to talk today about I'm going to focus on a totally novel strategy for addressing stimulant use in clinical practice. And as a little bit of background, some of the cases that I'll discuss are very similar to my real life cases. And the model actually came up. I was writing a paper on things that I'd love to do, sort of what would be the cutting edge of care for people who use methamphetamine in this case, but I think it corresponds to cocaine as well. And while writing that paper, I realized I needed a table. And so I created this table. And after creating the table, I realized, wow, this is pretty cool. I should try like following this exact model in my clinical practice. And I did, and it completely changed how people who use methamphetamine engaged with the interventions that I had to offer. So it was really exciting for me, and I've used it since then consistently with my patients in basically an HIV primary care setting. So people aren't coming to me specifically for addiction, they're coming for primary care in the context of HIV. So in general, my patients aren't necessarily interested in addressing their substance use. You can go ahead to the next slide. So I have no disclosures and advance from there. So this is the basic approach. And we're going to go into things in detail, but there's 4 components to it. The first is the assessment. The second is the routine prevention, things like vaccinations, screenings, everyone gets naloxone. The third is the use reduction interventions. That's usually what we're thinking about when we're seeing somebody with a substance use disorder. And the fourth is toxicity prevention, and this is the new one. I was asked to do this in 20 minutes, so I didn't include half of the talk, which is all about why there's a focus on toxicity prevention. But I'll try to summarize it as we go. Excuse me, I'm getting over a cold as well. The toxicity prevention piece is where basically everyone gets excited and everyone engages in this. It's kind of the harm reduction piece. I used to think that the routine prevention section, the vaccines and all that was kind of the harm reduction piece, but I actually think the toxicity prevention is even more so the harm reduction piece. When I talk to patients, I will explicitly say I have a 4-tier approach to addressing stimulant use, and I'll go through these 4 tiers, and when I get to toxicity prevention, their eyes light up and they engage like they never have before. Go ahead to the next slide. So I'm going to dive straight into cases. This is a cisgender man in his early 40s living with HIV, poorly controlled until recently, uses methamphetamine every day and has about 40 years of daily tobacco use, a half a pack a day, doesn't use any other drugs. So how are you going to start assessing or addressing his substance use? If this is a small enough group, I'm happy to, if people want to perk up and offer suggestions. Or I will just go ahead to the next slide. So the way I always start assessing somebody's substance use, I think the most important thing is understanding the benefits or perceived benefits that they get from their use. This is particularly important for stimulants because stimulants, in contrast to alcohol or even opioids, really have a functional benefit in somebody's life. You do. There's a reason I'm drinking a cup of tea right now. It's not just to soothe a sore throat. It's also because there's caffeine in there, and I could use a little bit of caffeine right now. So it's hopefully going to help me function in some way in my day. And likewise, people use stimulants. Sometimes it's to experience pleasure. Often, especially with unhoused people, it's to stay safe and alert on the streets. It can be to work long hours. There's a lot of history of stimulant use in medical training, 30-hour shifts, and also to manage pain or ADHD. I think a lot of people don't realize that stimulants have a mechanism and a proven analgesic benefit for chronic pain, particularly neuropathic pain. One of my patients, his sciatica completely melts away whenever he uses methamphetamine. And there are good data behind it. So it's not something we can ignore. It's really important to recognize that pain management is one of the purposes behind stimulant use. The next thing I do that is really ties into the toxicities that people experience from stimulant use, which are basically cardiovascular and neuropsychiatric, is I try to address the cumulative exposure, try to assess the cumulative exposure that they've had to the drug and their binge pattern use. So think of this a little bit like sort of a cross between tobacco and alcohol. I want to develop my pack year history equivalent, which we use a gram year history. And it can be tough for some people to know how much they use. In San Francisco, a gram of methamphetamine is $10, so that's pretty consistent. So I can ask how much they spend. I now, for at least research purposes, we now have a methamphetamine look-alike in resin, so we can show people different amounts and say how much they try to assess how much they're using. It's a little more difficult than a pack year history, but functionally it's the same. And how much cumulative exposure is a problem. We don't really know yet. There are no data on this measure, but I kind of think of it as, a gram year history of a few years, meaning a gram a day every day for a few years, isn't going to be associated with a lot of substantial toxicities yet. You're going to need more than that. However, the other piece that's really important, just like with alcohol, is binge pattern use. And that's with methamphetamine, you're basically just asking how many days do you stay up at a time when you're using methamphetamine. There are data to associate that with many of the toxic outcomes. And there are also plenty of data to associate me staying up too many nights as an intern and resident with a shorter lifespan. So if it shortened my lifespan, it almost certainly shortens the lifespan of people who are doing it while using methamphetamine. The next, of course, is your DSM-5 diagnosis, which I don't know about you all, but I find it it just kind of comes out in the process of a organic conversation. Then we get into a couple of other interesting pieces of the assessment that I don't think people usually think about with stimulants. One is I like to send a high sensitivity CRP. So methamphetamine use is associated with an elevated CRP, and there are some associations with less use being associated with a lower CRP. I have found by sending that CRP, which I like it because it's just clinically readily available. I don't like it because it's non-specific. It's also elevated with tobacco use. It's also elevated with a million other things. So the way I use the CRP is if it's usually when somebody's using a lot of methamphetamine, it comes back around 15 or so. And then when they come back and they say they've cut their methamphetamine use by 70%, it's down to 3 or 4. And I use it only exclusively for positive feedback. So if somebody comes to me and says, I've cut my use by 90%, I can send the CRP and I can say, your CRP dropped by 70%. That means there's less inflammation in your body. Let's keep on this path. It's good news. Another thing that I like to send early on in the course of assessing stimulant use is an EKG. Part of the reason I'm getting into the EKG is because the the mortality data that I've looked at, and I think most of the deaths from stimulants are due to ventricular arrhythmias. And when I look at the EKGs of people who died, whose death was attributed to acute stimulant toxicity, they they almost uniformly have elevated prolonged QTC intervals. So the EKG is really to look at that QTC interval. And frankly, it's to get a sense of how much they are at risk for an arrhythmic death in the near future. The next thing is a cardiovascular risk profile. And there's a big problem with this because it doesn't include stimulant use in their risk profile. But if you run that risk profile and they're at 5% risk and you mentally add in their stimulant use, they're over 7.5% risk, clearly. So if you can do a little adjustment yourself post risk profile, you can get a sense as to where they're really at. Next slide. So this gentleman, Peter, he uses mostly in the morning to focus, to get things done. Occasionally he uses in the evening with friends. He has a 25-gram-a-year history. He never goes on runs. He always goes to sleep every night. He's usually employed, works as, a mechanic, machinist, and he can stop using whenever he needs to. He can stop using for a week and pass urine screens. He never has withdrawal. He's not interested in changing his use. His teeth are rotten, and he attributes that to his meth use, and that's his only use disorder criterion. So he does not have a use disorder. So what are you going to do next? Any thoughts? Or we'll just head to the next slide.
I think Greg has his hand up.
Yeah.
I just had a quick question. I just make sure I have clarification for the gram year stuff. So for 25 years, do you just like average that out? Is that kind of what you use? Okay. So if like 1 year was like half a gram, 1 year was like 1.5, the average would be 1 gram year.
Yeah, I'm just asking how much you use a day, how long have you used, and then you're multiplying it. That's what I'm doing clinically because everything we do clinically is the quick and dirty. If I was doing it in a research setting, I would be like, did you ever have any prolonged periods where you weren't using? I'd try to get a more nuanced assessment of their actual exposure.
Okay,
but I don't have the data behind that measure. For me, it's just to get a rough sense. If it's a few years, not a big deal. If it's dozens of years, then probably significant toxicity. Any other comments or questions?
I think with this patient, I would really focus on like the poor dentition because he's already at a higher risk for cardiomyopathy with the stimulant use. And then also, even though he's not interested in changing his use patterns, letting him know about like alternative prescription-based amphetamines that might help with his focus and drive to get things done.
I love it.
And I'm interested in finding out, I guess we don't know why that person is there. But, so what are you interested in? Well, why are you seeing me today? How can I help you? What's your goal? Because it's not clear what their goal might be.
He's there for HIV primary care.
Okay, great. So I think that's very interesting. So he's not there. So I think it's something, it says he's not interested in changing use. But if there's any education, you can start providing if they're interested, or ask if there's any information they'd like about impact on, your dental health or risks there that might be worth exploring. But I think it's challenging if they don't really want to address that right there and want to make sure that they do continue coming back for their HIV related care.
Yeah, exactly, Elliot. Part of the reason I went into infectious disease is because I thought I found HIV practitioners to be nice to people who use drugs. And that was a win for me. And so I wanted to be part of that community. When I finished my training and I entered that community, I was actually really disappointed with the community because they were nice to people who use drugs, but they didn't deploy any tools to actively address the drug use. And so I was really disappointed with my colleagues. You know, I, this work is at a clinic, that works with uninsured and publicly insured patients. And there was only one other practitioner there at the time who provided any buprenorphine at all. And, you know, at that time, prescribing opioids was, really frankly used as a tool to keep people engaged with their HIV care, and their addiction wasn't being addressed. And it was really disappointing. I think it's improved somewhat, but there's still a long way to go. Go ahead to the next slide. The nice thing about being in an HIV clinic is all of this sort of what I call panel management or general preventive strategies is basically done already. I like these tools a lot because most medical professionals know how to deliver screenings and vaccinations. And saying that delivering screenings and vaccinations is part of caring for somebody who uses drugs gives providers something that a tool that they know how to do that checks a box. So they can say, I'm addressing their substance use by doing these screenings and doing these vaccinations. And I always feel very strongly that one of the biggest contributors to stigma in medicine is when a healthcare provider doesn't feel like they have anything to offer the patient. Why is this patient seeing me? I have nothing for them. It's a waste of my time. It's a waste of their time. So that creates a negative and a stigmatizing interaction. So I really like to give tools to providers that they can do, even if they're simple checkbox tools that they can do so that they feel empowered working with a patient who uses drugs. Provider feels empowered, patients usually feel more cared for. And so I'm very aggressive with screenings and vaccinations, annual for the screenings, really aggressive with vaccinations, remind people that, the HPV vaccination is through age 45. That's cool. A lot of people forget that. And, preventing cancer in your orifices is a really, really amazing goal. Naloxone to everybody, regardless of opioid use, because we know there's a lot of unintentional fentanyl use out there, whether picking up the wrong tool or getting a drug that you thought was a stimulant because it looked like crack rocks. And however it happens, there's a lot of unintentional fentanyl use, and everyone should be carrying naloxone. Pre-exposure HIV prophylaxis, PrEP, ideally with long-acting injectables if you can get your hands on them, and post-exposure STI prophylaxis with doxycycline. These are great tools. And then, of course, if you have it, support for housing, insurance, food, and I should actually add in there dental care, which of course we talk about with patients. And I do think that is one of the foci, and is a mechanism of trying to reduce the harms of the substance use, because the rotten teeth are contributing to cardiovascular harms. Next slide. So I'm skipping over use reduction in this case because when I got to use reduction, as Elliot suggested, this person's not interested. I briefly mentioned the medications that I could offer. And then I said, the next thing I want to talk about is addressing toxicities. So the two main pathways to toxicity for stimulants are cardiovascular and neuropsychiatric. So cardiovascular, not just heart attacks, but heart failure, aortic dissections, strokes, etc. Neuropsychiatric, cognitive decline, memory issues, executive functioning issues, psychosis, earlier onset of Parkinsonian symptoms. And we don't have anything proven to prevent these toxicities besides reducing use. We do, however, have some things that likely, almost certainly, will contribute to it. Smoking cessation will contribute to a reduction in your cardiovascular disease development. We know that. Aggressive management of sleep is really important. I don't have the answer to how yet. I've been, I was indoctrinated by sleep experts who told me that pharmacologically assisted sleep is bad because it's not as good as normal sleep. However, a lot of my patients use methamphetamine, don't get any sleep at all. So pharmacologically assisted sleep is probably better than no sleep. I'm still more conservative with sleep aids than I probably should be in this population. I don't know what the right answer is, but I do think we have to address it more aggressively than we do and maybe be willing to prescribe some sleep aids. Viva la Lunesta. Just reading the chat. The third thing, and this is the big one really, is statins. And I come from the HIV world, and I'm going to talk more about statins on the next slide. But in the HIV world, we're now allowed to use statins for anybody because HIV supposedly contributes to cardiovascular disease, and statins for people with HIV who don't have an indication for statins reduce cardiovascular events and overall mortality substantially. I wonder if that study was confounded by undermeasured stimulant use. And it was actually the stimulant use that was contributing to this, and the statins were preventing the events and deaths that were actually associated with the stimulant use. The data are not there in the study because HIV research in general doesn't include high quality drug use collection data. It's a really unfortunate issue with HIV studies. Briefly, I'll mention on the treatment side of things. So for cardiovascular disease, people who use stimulants should receive goal-directed medical therapy, which is the whole cheech. It's everything you're supposed to get when you have heart failure. And there's a lot of fear about using beta blockers in people who use stimulants, and that is based on a myth propagated since the 1970s. A small letter to the editor that said we can't give beta blockers to people who use cocaine because of unopposed alpha stimulation, and that was disproven multiple times in multiple analyses for the next 40 years. However, it was still repeated even on my favorite medical show ever, The Pit. Noah Wiley, unfortunately, reinforced the delusion that you can't give beta blockers to people who are on a stimulant. It was so disappointing. Otherwise, I love the show. So don't shy away from beta blockers. If you still just can't get yourself to get over the fear of beta blockers and people using stimulants, use carvedilol because it also has alpha blocking capacities, or labetalol because it also has alpha blocking capacities. So you can use one of those if you just can't let go of the myth. And for treatment of psychiatric disease, it's really about atypical antipsychotics. For chronic treatment. For acute treatment, droperidol actually, interestingly, has the best data because it also seems to help with some of the vascular issues. Go ahead to the next slide. So Peter, as Elliot predicted, doesn't want to reduce his use, but his eyes lit up when I mentioned toxicities, and he got really into it. He was thrilled to accept a statin. And the question comes, who do I give a statin to? Go ahead to the next slide. And what's my data behind a statin? So there's a little more data than this. This slide's a little bit old, but not much. My data behind a statin is mostly animal model and hypothetical. For cardiovascular disease, it's actually the weakest, probably. We know statins we know that the stimulants induce cardiovascular disease through inflammatory mechanisms. I used to think it was persistent high blood pressure and tachycardia, but it's not. It's actually hand-wavy cytokine-mediated inflammatory mechanisms and mitochondrial-mediated toxicity, which are the same mechanisms that statins help to modulate, as well as other agents like our flozins. The Reprieve study, which I mentioned before, showed a profound reduction in cardiovascular events and death in people with HIV who didn't have an indication for statins. Atorvastatin definitely reduces the thrombotic effects of cocaine. So, cocaine has that coronary artery disease, plaque development, and thrombosis effect that methamphetamine doesn't really have that so much. And that is definitely reduced by statins. And then the flozins in an animal model prevented meth-induced cardiomyopathy. So on the neuropsychiatric end, the data actually for me are a little bit more compelling, and I didn't include in here some of the human data. We know in humans, statins are associated with slower onset of dementia and Parkinson's disease, and stimulants, particularly methamphetamine, are associated with a earlier and more significant onset of Parkinson's. So what I think is going on from all the other data is that you're getting less dopaminergic cell apoptosis. And so you're preserving some of that neural function that would otherwise be lost. We know that the statins, particularly atorvastatin and rosuvastatin, reduce the learning and memory impairment in rats that's associated with MDMA and the Parkinsonian symptoms and neurocytotoxicity. So I don't think it's going to affect psychosis, but it may slow the cognitive decline that you see with chronic, heavy, long-term use. Next slide. So Peter comes back a month later, and he literally says this to me. Doc, I've been taking the statin, and no issues, it's totally fine. But I was thinking, if I really want to reduce my toxicities, I should probably reduce my use. You said you had some medications that might help with that. It's literally the words that came out of the guy's mouth. And then he's psyched to take bupropion, which I picked because he's using methamphetamine to wake up and get his stuff done. And bupropion is a stimulating agent. So it's a good choice for somebody who's using methamphetamine for stimulation to get stuff done. And then on his way out, he schedules monthly visits, and he comes back every month to tell me about his methamphetamine use and his tobacco use. He's down to weekly use and at most 2 cigarettes a day. And his CRP drops from 15 to 3. That was my first experience using this model. Any questions about that? I'll try to take a look at the chat and see if there's anything in there. Sleep's incredibly important. Yeah.
I just love this. I think bupropion's so underused in clinical settings with stimulant users. I had the privilege of working with a doc for a while that was doing just this. And it was always great outcomes, like almost always. They were like, yeah, I quit smoking and I'm sleeping and everything's great.
Yeah, I agree, bro. Sometimes you see it like it's almost like, buprenorphine back in the heroin days. It could just melt the disease away. It was amazing. And I like to, one of the issues we have sometimes is dose. So patients often don't want to push the dose high. I do try to encourage them to push the dose up. A dose of 450 is more associated with better cessation of stimulant use. You do want an EKG if you're going up to 450 because of the QTC concern. Most patients I find stop at 300 and aren't comfortable going above that. But our data are better at the higher doses. Next slide. All right, our next patient, another man with HIV, using methamphetamine most days, going on runs 3 to 4 days at a time. He's been to psych emergency and put on a 5150, which is California's involuntary hold, twice in the last year. He only gets psychotic when he's on a run. What can we do about his psychotic symptoms?
Well, we've already talked about it, but I mean, when I think about that, we're thinking about a situation where someone likely hasn't been sleeping at all. So it's really not much of a surprise that we would develop psychosis. So, I mean, there's, potential for direct drug-induced psychosis, but more likely, I would say that we're seeing someone that really needs to get some sleep. So I think that's something that's going to be the most important thing to address, at least immediately and longer term. If depending on if some people can use meth and then go to sleep, but if they're doing this, for 3 to 4 days at a time and going on a run, as you say, I would be looking at, well, you're not sleeping, so this is why this is happening, and talk about how the drug use can impact that.
I love that. You took it in a direction I didn't expect, but that I completely agree with. Go ahead to the next slide. So a little bit on psychosis in people who are using methamphetamine. About this was a little local analysis that we did of people who used methamphetamine, and 72% had psychiatric symptoms from their meth use in the past 30 days, and half of those people had an adverse event from their meth use, from those related to those symptoms: an emergency ED visit, injury, altercation, police interaction, psych hospitalization. Go ahead to the next slide. So we developed this program in San Francisco, which we called chill packs, or methamphetamine assist packs. And these consisted of 4 tabs of 5 milligrams of sublingual olanzapine to be taken as needed for people when they start having symptoms. If you jump to the next slide. This is the backside of our trifold. So it gives you a little bit of information. What we said was meth can make you anxious, agitated, fearful, hear voices. Olanzapine can help if you feel anxious, fearful voices, can't fall asleep. And the kit only had 4 tabs. So the total, even if they took all 4, they're still within the FDA daily dose for chronic olanzapine use. The dose for acute olanzapine use is 30 milligrams, so the 20 milligrams is still within our chronic use. So we weren't really worried about side effects besides sleepiness and dry mouth. That's what you're going to get acutely. And what they're, up to now at least, there's no street value for olanzapine like there is with Seroquel and things like that. So the other reason we picked olanzapine was because there are really no drug-drug interactions. It's the best one to go to in the ED if you don't know what's going on with the patient. And you don't know, that the QT effects are minimal. So if you don't have an EKG, it's still safe to administer olanzapine in an acutely psychotic patient in the emergency department. So bunch of reasons we picked it, and we ran this program out of psychiatric emergency services at the public hospital. And I have some data on that. If you can go to the next slide. So this was just observational. It was the first 92 patients who got a chill pack, and they had about their relative risk of an emergency department visit declined by over 30% for the next 2 months, and then slowly normalized over a year. So we did see a reduction acutely in ED visits with the chill pack. So there's a good amount of prescribing of this going on in San Francisco because we have a good amount of methamphetamine use and a good amount of psychotic issues.
What was the baseline number? I don't see that here.
Yeah, sorry, this is an incident risk ratio, so it's not giving the baseline number. That's in the manuscript, which if you look up a methamphetamine assist pack in my last name, you'll see the manuscript. I don't remember off the top of my head. I don't remember what the average was. I think the average number of visits per month was probably like a half a visit a month. These were frequent flyers, people who were in psych emergency several times a year in general. And it was, some of them really should have been on chronic long-term or ideally long-acting injectable antipsychotics. Yeah. In terms of additional data for this, so this program, there's a lot of additional data I could talk about, but we did manage to track down and interview about 12 people, 12 of these 92 people, and all but one had used the chill packs. And everyone who used it said the reason they used it was because they got they were hearing voices, seeing things, or were just way too high.
Well,
And yeah,
sorry, go ahead.
no, please.
I was just gonna say this is I love this concept because there's I've worked with a lot of people who have lived mental health experience in terms of serious mental health issues, and one of those people I spoke with a couple months back just said something that kind of stuck with me, and was just talking about how much, they've been someone who's been in and out of the psych hospital, and have used controlled substances, but I'm not sure they've used methamphetamine necessarily. But they said, I only wish that I could just, when I'm having some of my symptoms return, psychosis related symptoms, that I could just call my doctor and just get a short-term supply to use as I need. But they fear so much that they're going to be stuck back in the psych hospital if they call and reach out about the fact that they're having psychotic symptoms again. And, a lot of times we see people also given much higher doses than needed immediately for treatment. And I think a short-term use it when you need it approach is really how we should be using antipsychotics in a lot of cases, and not as much you need to be on an antipsychotic or you're not well, which is how society seems to treat a lot of people with severe mental illness. I just wanted to mention that.
Thank you so much for saying that, Elliot. I completely agree. And when I first this program was recommended to me by a colleague who I initially poo-pooed it. I had the same reaction. I'm ashamed to say I had a similar reaction that people had when, back when I started doing naloxone work in the 90s, a lot of people said, "Oh, you can't give people who use drugs naloxone. They won't know how to use it. They won't use it when they need it," all that stuff. It was grossly proven wrong and completely incorrect. When this concept was proposed to me, my initial thought was they're psychotic. People who use methamphetamine can't even take their medications. Their adherence to medications is really problematic, even when they're not psychotic. And when they're psychotic, they're going to reach in and take a medication to address their psychosis. That doesn't seem reasonable. But I thought about it. I thought that's exactly the attitude people had about naloxone 30 years ago. Am I falling into that old trap? And so, the least you can do in this kind of scenario is give people the benefit of the doubt and see if they can do it. And they did it. Like, at least, the data suggests that they did it, and the 12 people we found suggest that they did it. We did design a randomized controlled trial that, due to the federal funding issues, got a near perfect score at NIH, but has not been funded. So we don't have our RCT data or really good follow-up data, unfortunately. But if it's an issue, I think these data are enough to reach outside of the box and offer it to a patient.
And the other thing, just to quickly add, is that there are a lot of people do have close friends, a significant other or other family members who are in their life, checking in on them or interacting, who can help some who may not always think to jump to, remembering to take my medication. So that's if you have a supportive environment, which unfortunately not everyone has. But I think you're right that people can function more than people give them credit for, especially people who have been through things before and have learned more about their diagnosis or things that happened to them and so on. So anyway, I appreciate all of this.
And comments in the chat about autonomy. Yeah, I very much agree. Especially people who are suffering from psychiatric issues, autonomy is frequently stripped. Next slide. Okay, I realize my 20-minute talk has gone way over. I hope this is okay. We're doing cases.
Yeah,
You're
no worries.
completely
Keep
okay.
going.
Keep going. We love it. I think we're all learning a lot, so keep rolling with it. Yeah.
So this somewhat younger gentleman, gay man, using methamphetamine 3 or 4 times a day, 3 or 4 times weekly at night, goes on brief runs, relatively low BMI, no cardiovascular neuropsych symptoms. He really wants to stop using. He does not want to use meth. He's gone to inpatient rehab a couple of times. It doesn't stick. He picked me out of the HIV providers because he looked me up and found out what I did and really wanted help stopping using methamphetamine. So, any thoughts on what you might offer this guy first before we jump to the what I did? Let's jump ahead in the interest of time. So this is the chart that we use in San Francisco to train providers in how to manage stimulant use when you're trying to reduce use. Contingency management, most important. If you have it, if you can access it, most people can't. There are programs out that, California has Medicaid, Medi-Cal reimbursed contingency management programs now, but they are tied to addiction clinics. They're not yet in FQHCs. San Francisco, we have locally funded contingency management programs, some, NGO, philanthropic funded contingency management programs. And so we have places that we can send people. It's our most evidence-based intervention for reducing stimulant use. And there are some fresh data out of the VA this week that it actually reduces mortality. So that's pretty exciting. The two drugs that are my first go-to drugs for stimulant use are bupropion and mirtazapine. Mirtazapine only has data for methamphetamine. Bupropion has data for both cocaine and methamphetamine. How do I pick one or the other? It's pretty simple. Bupropion is activating, mirtazapine is sedating. If you're using at night to go out, or you're using at night after you go out at 1 o'clock in the morning, when you come back drunk, when you leave the bar, you start doing meth and stay up for days. Mirtazapine's a great option because hopefully maybe you'll be a little bit sedated. I don't know. Sleep wasn't associated with the benefit, but it was so I don't think it's just working through sleep. And the sedating aspects of mirtazapine are kind of Benadryl-like, and you do get somewhat inured to them over time. The other reason to think about mirtazapine if somebody's really skinny and can afford to gain some weight, because you do put on a little bit of weight with mirtazapine. The dose we use is 30 milligrams, and it is that you don't get a lot of weight gain. About 10% of people get weight gain. If you bump it up to 45 milligrams, almost everybody puts on 20 pounds. So I usually try to restrict it to 30 milligrams. Bupropion has the smoking cessation benefit. And so, that's very common. And that activating thing, that if people are using it to get things done or stay up and stay safe, bupropion might be a better option. You do have some cardiovascular contraindications for bupropion, including QTc intervals, uncontrolled hypertension, heart failure. Sometimes it's worth pushing through those contraindications to help somebody reduce their meth use. Somebody who has heart failure, sometimes the advanced heart failure clinics will add on Wellbutrin, even though they have bad heart failure, because getting the cigarettes and the meth out of the picture is more important than the risk posed by the medication. But that is, if you're a trepidatious primary care internist, you're going to be more cautious than that. A lot of psychiatrists combine bupropion and mirtazapine because they love combining dozens of serotonergic agents together and are very comfortable with it. Internists generally aren't, so they'll usually stick with one or the other. Adding on naltrexone. So the ADAPT-2 study showed that IM naltrexone with high-dose bupropion at 450 milligrams, incentivized with $5 a day for taking your pills, led to substantial meth use reduction among people who had really heavy and problematic methamphetamine use. The other IM naltrexone studies didn't really show a benefit by itself. I have definitely seen patients on IM naltrexone for other reasons who have zero interest in continuing their stimulant use. And so I think it does help some people. And PO naltrexone actually has a little bit of better data with methamphetamine. So basically how I use it is I start one of these drugs and I'll add on oral, or if I can get it in, and the patient really wants more intensive intervention, injectable naltrexone, and try to do that Q3 week intervals for the injectable naltrexone to keep the levels high. I see Amber's hand is raised. Do you have a chime in?
Yeah, I just wanted, so I know what contingency management is, but I contingency management is not widely available in Tennessee, so there's probably folks on this call who don't even know what that term means. Would you mind just giving us like a brief, broad stroke of what contingency management is?
Sure. So with contingency management, you're doing point in time reinforcement of desired behaviors with incentives. So for example, you're giving somebody money if they have a negative urine. There's a couple key things. One is you want to have it timely so that you're not sending off the urine and then calling them a week later and saying congratulations, you get $5. You're doing it in the moment because you're using old psychology theories to drive this. And then the second, another key piece is you want to make sure that the incentive is meaningful. 50 cents is not meaningful. So you want to be giving them something that actually gives them some drive to continue the behavior. Going beyond those medications generally, I think, requires an addiction medicine consult, and that's to things like topiramate or psychostimulants. Topiramate, it's in the guidelines from the ASAM, but the data for it for meth are terrible. The data for it with cocaine are in the context of also being on a psychostimulant. So topiramate, I wouldn't use it for methamphetamine unless I was also trying to suppress alcohol use, because it's got better data for alcohol. Psychostimulants are a little bit different. In this chart, which is guided towards California providers, it says if you're also treating ADHD, because California law is more restrictive than federal law. In California, I can't prescribe for more than 30 days a controlled substance to treat a substance use disorder unless it's FDA approved for that indication. So I can still prescribe, a psychostimulant to treat ADHD, and part of my treatment outcome can be reduction in methamphetamine or cocaine use, but it can't be the primary disease I'm treating, can't be an addiction. So we're a little bit hamstrung there, but it is true, a lot of people with methamphetamine use disorder also suffer from ADHD. Next slide. Okay, I'm going to try to run through it quickly because we've only got a few minutes. So Paul starts mirtazapine. His use cuts to about twice a month. When he goes out drinking with friends, he starts using meth around 1 a.m. and continues for another day. And he really hates these relapses. He doesn't want to do it. It makes him really unhappy. He wants to bump his dose up to 45 milligrams. He's kind of doing it himself sometimes. I'm discouraging him because I think he's going to jump to a BMI of 27 and be really unhappy and end up using meth to try to reduce his weight. So next slide. I added on naltrexone 50 milligrams daily. Now, I also said you can just take this on the weekends. We have data that intermittent naltrexone helps with binge drinking. So if you have a patient that just drinks on the weekends and they want to cut back on their use, they can take a naltrexone pill on Friday and they'll go out Friday night. And many of them, it doesn't work for everybody, of course, but oftentimes they will end up, we did a nice trial on this, they will end up having, 1 or 2 drinks instead of 7 or 8 and not getting into trouble. And so that's exactly what happened with him. He didn't use it every day. He just used it on the weekends when he tended to go out. And he ended up not staying up, not coming home at 1 o'clock in the morning drunk and starting to use meth. And his relapses dropped to every few months. Next slide. Yeah, I was just reading the note from Elliot about naltrexone being used for opioid use disorder. I mean, first thing, you should never ever use oral naltrexone for opioid use disorder. It is associated with a super high mortality. I think it's malpractice, frankly. Injectable naltrexone is approved based on a study out of Russia that I still have major issues with. And I don't find it useful for most of our patients. I do think it is useful if you have a professional reason you cannot consume opioid agonists, such as a surgeon or a pilot. But for most of the patients we're working with, injectable naltrexone is not desired, and the outcomes are not as well documented. So just to conclude this briefly, an assessment, patient goals, what are they looking for? Gram-year history, binge use. Give everyone naloxone, screen vaccinate, PrEP, doxypep. Bupropion, mirtazapine, naltrexone are kind of the first line, non-controversial medications that I think everyone should be able to use. And toxicity prevention, smoking, statins, and sleep while looking at a CRP and possibly an EKG. And I also want to throw out there, if you're starting a statin on someone who uses stimulants, I like to send a CK beforehand, because sometimes creatinine kinase, which is a sign of a little bit of muscle breakdown, sometimes people who use stimulants have chronically elevated CK, and statins can also elevate the CK in a statin myopathy muscle disorder. And if a patient comes back to me and says, hey, my muscles are hurting from the statin, and I want to see if they have a muscle disorder, and I send a CK and it's elevated to 500, and I didn't send a baseline and know that it was already elevated to 500 in that patient from their stimulant use, then I'm going to label them as having a contraindication to statins. And statins are going to be off their medical record. And then when they really need a statin because they're having heart attacks every other day, they can't get one because it's listed as an allergy. So I don't want to screw them out of a real legit need for a statin later by giving it to them preventively without knowing their baseline data. I'm done. I know we're almost out of time. I'm happy to stay for any questions.
Thank you so much, Dr. Coffin. That was like so much